Okay, I want you to think back to your very last doctor's visit. You know the drill. You're sitting there on that incredibly loud, crinkly paper, answering a million questions. But did you ever stop and wonder if your entire perception of the care you were getting was actually being secretly manipulated? Like, is there any chance your confidence in your diagnosis was literally shaped by the exact shirt and tie your doctor just happened to pull out of the closet that morning? Well, welcome to The Explainer. Today, we are completely unpacking the hidden psychological forces that are constantly at play every single time we interact with the medical system. So, we are going to be tracking the patient's journey today through 5 major steps. We'll start with why we delay seeking help, then look at first impressions and jargon, move on to delivering the diagnosis, figure out the best consultation style, and finally, look at a really extreme case called faking it, Munchausen syndrome. All right, let's dive right into part 1, why we delay seeking help. To kick things off, let's look at a really classic piece of research from Safer and colleagues back in 1979. They wanted to explore the psychological hurdles that actually cause patients to put off getting treatment. And get this, they found that patients delayed, on average, a whopping 57 days from the moment they first noticed a symptom to the moment they actually saw a doctor. Nearly 2 months? This flowchart brilliantly illustrates why that happens. Basically, there are 3 distinct psychological checkpoints of delay. First step is appraisal delay. That's when you're just trying to decide if you are actually sick. Next is illness delay, deciding if you really need professional care for it. And finally, utilization delay, weighing if going to the clinic is actually worth the cost, the time, and the effort. You literally have to pass all 3 of these psychological roadblocks just to make it into the waiting room. Now, what is super fascinating here is the actual data breaking down those delay times. Unsurprisingly, right, if you're experiencing severe pain, you really don't wait long, usually about 8.5 days, compared to over 23 days if you aren't in pain. Makes total sense. But check out those bottom 2 rows. You would naturally think that researching your symptoms would prompt you to go to the doctor much faster. I mean, we all look up our symptoms, right? Well, actually, it's the exact opposite. The totally counterintuitive finding here is that reading a lot about a symptom drastically shoots your delay time up to over 50 days, compared to just 11.5 days if you only read a little bit. It really seems like over-researching might actually convince us we can just handle it ourselves, or honestly, it just paralyzes us with anxiety. Okay, moving right along to part 2, first impressions and jargon. So you finally make it into the clinic, and immediately we hit the clash of visuals and complex medical terminology. Just take a look at these photos from a really fascinating 1991 study by McKinstry and Wong. They tested over 400 patients to see exactly how nonverbal communication, specifically what the doctor is wearing, affected patient trust. Look at the screen and ask yourself honestly, which of these doctors immediately makes you feel more confident in their abilities? Does a crisp white coat make you feel better? What about a casual sweater? Or maybe jeans? Well, the data shows that patients overwhelmingly favored formal attire. For male doctors specifically, 67% of patients preferred a tie and 44% preferred a full suit. That far outpaces the traditional white coat, which only got 15%. Plus, patients were highly likely to actively object to doctors wearing jeans or earrings. So what does this tell us? It completely proves that a doctor's wardrobe significantly biases our perception of their medical competence before they even open their mouths to say a single word. It's wild. But hey, the disconnect between patient and practitioner isn't just visual, it's incredibly verbal too. Let's do a quick test. Take a second and ask yourself, do you know what the medical term breech means, specifically in a maternity context? Let's see how this exact thing builds into a major communications gap. A classic 1975 study by McKinley investigated how well working-class mothers in Scotland actually understood medical terms, and then compared that to how well doctors thought they understood them. Look at this huge mismatch. For the word breech, doctors estimated that a mere 22% of these patients would understand it. But the reality? Between 84% and 100% of the patients actually understood the term perfectly well. McKinley revealed this massive gap, proving that doctors consistently and severely underestimate the medical vocabulary of everyday working-class patients. And this is a big deal, because it leads doctors to either talk down to patients or just throw terminology around without ever expecting them to grasp it. It totally damages the patient-doctor relationship. Which brings us to part 3, delivering the diagnosis. Getting the actual news is, without a doubt, a moment absolutely loaded with anxiety, not to mention the very heavy risk of physician error. When a practitioner makes a diagnosis based on what the patient tells them, errors usually fall into 2 incredibly dangerous categories. First, you have a false positive. That's when a totally healthy patient is incorrectly diagnosed with an illness. And obviously, this causes massive, completely unnecessary anxiety, forces severe lifestyle changes, and can lead to harmful side effects from unneeded medication. On the flip side, though, a false negative is when an unwell patient is misdiagnosed as perfectly healthy, and this one can literally be fatal because the patient just goes untreated while their true condition silently worsens. Now, making an accurate diagnosis is one thing, but how patients actually want to hear that news is a whole different story. If the news is bad, you'd probably just assume everyone wants a compassionate, face-to-face conversation, right? Well, a 2016 study by Cook and Culver found that a shocking 48% of patients actually preferred to receive a suspected skin cancer diagnosis via a physical letter in the mail. Another 37% wanted it over the telephone. Only 11% actually preferred face-to-face. When you think about it, a letter allows the patient to process that really heavy news in complete privacy. They can reread it to make sure they understand it fully, and it entirely avoids an immediate, highly emotional, and public reaction sitting there at the hospital.
All right, let's pivot to part 4, the best consultation style.
Looking closely at the physical dynamic of the consultation itself, researchers Savage and Armstrong ran this absolutely brilliant field experiment back in 1990 to see exactly how the doctor's interpersonal attitude changes your satisfaction. They had a general practitioner randomly adopt one of two specific styles for 200 different patients. On the left side here, we have the directing style. This one is super authoritative. The doctor entirely dominates the conversation. They ask closed-ended questions and basically just tell the patient what is wrong and exactly what to do about it. Then on the right is the sharing style. This is much more collaborative, patient-centered. The doctor asks open questions like, "Hey, what do you think is wrong?" And they make decisions jointly. So which one do you honestly think patients preferred? Well, here is the incredible twist. Savage and Armstrong concluded that for simple, everyday physical ailments, patients actually reported much higher satisfaction and felt they received a much better explanation when the doctor used the directing style. Yeah, patients essentially wanted the doctor to just take total control and boss them around a little bit. It totally contradicts the general view that a warm, fuzzy, shared style is always the best approach. It turns out, for a basic physical illness, patients actually derive a ton of comfort and confidence from an authoritative figure who just steps in and takes charge of the situation.
Finally, we arrive at part 5, faking it, Munchausen syndrome.
To close out our patient journey today, we're going to look at the absolute extreme outlier. This is what happens when a patient games the entire medical system purely for psychological gain. We're talking about Munchausen syndrome. Now, this is a very serious factitious disorder where someone deliberately makes themselves genuinely unwell or fakes very severe symptoms. But what's absolutely crucial to understand here is how it differs from simple malingering. See, a malingerer fakes being sick to get a tangible reward, like cashing a disability check, winning a lawsuit, or honestly just skipping out on work. But someone with Munchausen syndrome, they have zero external incentives. They will willingly undergo intensely painful procedures, massive surgeries, and endless hospitalizations purely for the psychological comfort and the attention that comes with playing the sick role. A textbook example of this is a truly fascinating 1995 case study documented by researchers Aleem and Ajariam. They reported on a 22-year-old female university student who presented with just an incredibly complex, baffling medical history. She initially had some immune issues, but then suddenly developed deep vein thrombosis, which are very dangerous blood clots. But it got even worse. She began developing these extremely painful abscesses in her groin and breasts. Over a prolonged period of time, these totally unexplained migrating abscesses required over 20 surgical drainages and hospitalizations. The medical staff was completely, utterly baffled. Live tests were showing an array of different random organisms causing the infections, but there was absolutely no logical medical explanation for why this kept happening to her. This huge medical mystery was only solved when a nurse happened to notice something slightly out of place and discovered a hidden syringe tucked away in the patient's belongings. And that single piece of evidence brought the whole house of cards crashing down. It revealed that the patient was secretly and repeatedly injecting herself with highly contaminated material, likely fecal matter or dirty water, just to deliberately cause these terrible, disfiguring infections. When she was finally confronted with this reality by the hospital's psychiatric team, the patient became incredibly angry, super defensive, and ultimately, she just fled the hospital completely against medical advice. It's obviously a really dark and extreme example, but I think it perfectly highlights the completely invisible psychological undercurrents that are flowing through every single hospital hallway and exam room out there. Literally, from the exact clothes your doctor chooses to wear to earn your trust, all the way to the agonizing days we spend stressing over symptoms online, our medical journeys are so deeply psychological. So, knowing all of this, I want to leave you with a question to ponder. The very next time you put on one of those crinkly paper gowns, sit yourself down on that cold exam table and wait for the doctor to finally walk in. Are you truly acting like yourself, or are you just playing a psychological role? Thanks so much for exploring this totally fascinating topic with me. Keep asking questions, and I'll catch you in the next explainer.